For all history shows that the effort to win progress within freedom represents the most determined and steadfast aspirations of man.
Good afternoon, good morning, or good evening from wherever you are. I'm MacKenzie. I'm Dean of the Johns Hopkins Bloomberg School of Public Health. It is a great pleasure to welcome you to the Johns Hopkins Health Policy Forum. This is the fifth installment of a series that brings leaders together to discuss pressing health challenges and how to approach them through effective policies. Today, I am so excited to speak with someone whose mission and passions are closely aligned with those of the Bloomberg School, someone who can offer us vital perspectives on how to build a healthier future for all. Joining us for today's virtual fireside chat is Dr. Atul Gawande, a health policy expert, renowned surgeon, professor, author, and public health leader. And in January, he started an exciting new role as Assistant Administrator for Global Health at the United States Agency for International Development, or USAID. As you can see, Dr. Gawande has already been quite busy. In his first months on the job, he traveled to Nigeria, where USAID is working with local partners to accelerate COVID vaccination rates and ensure distribution of medications for neglected tropical diseases, as well as partnering with Gavi on routine childhood immunizations. And earlier this week, he was in Poland, where he met with USAID colleagues and a number of other partners who are delivering critical assistance in response to the war in Ukraine. And of course, he's just getting started. So first, some background. Since its creation by President John F. Kennedy in 1961, USAID has committed to improving health security and well-being around the world, as you saw in the opening video. The organization leads humanitarian efforts to save lives, reduce poverty, and very importantly, to provide other nations with the support they need to lead their own development efforts. At USAID, Dr. Gawande will focus on strengthening health systems and spreading health equity worldwide. He'll tell us more about that in just a moment. But Dr. Gawande is very well positioned to thrive in his new role. Previously, he was a practicing general and endocrine surgeon at Brigham and Women's Hospital and a professor at Harvard Medical School and the Harvard T.H. Chan School of Public Health. He has led transformative health initiatives, among them a cross-disciplinary health system innovation center, a nonprofit that makes surgery safer on a global scale, and a health technology company that facilitated millions of COVID-19 tests. These efforts reflect his deep understanding and broad vision of what it is needed in public health and healthcare. As you may know, Dr. Gawande was a longtime staff writer for the New Yorker magazine and is the author of several best-selling books. His writing is gripping and deeply humane. He examines the realities of medicine and surgery and asks bracing questions that many aspects of healthcare, as well as about life and death. Over the past 2 years, The pandemic has taught us many harsh lessons and raised many such questions about the need to reimagine and strengthen health systems around the world. We now have the chance to take that disruption caused by COVID-19 and turn it into a real opportunity to focus on preparedness and prevention. And I'm sure Dr. Gawande will have many ideas to share with us about that. So Dr. Gawande, welcome. It is such a pleasure to have you here as our guest at this Johns Hopkins Health Policy Forum. So before we jump into some questions, we've got lots of questions, I'd like to give you an opportunity to offer some welcoming remarks. Dr. Gawande?
Dean, thank you for this invitation. Thank you to the Johns Hopkins Bloomberg School of Public Health. You've been hosting an important series, and I feel very fortunate to be asked to join. I wanted to start off by saying a little bit about how I ended up deciding to take this role. I have had a long career in surgery, in writing, and also in public health. That's probably less known part of what I do, but in fact, it's been the majority of my time building a center called Ariadne Labs, where we did health systems innovations and doing a variety of other work around the world that was discussed in my bio. But the theme of the work has been that really, which I learned from Paul Farmer, who was at the Brigham and Women's Hospital with me as we went through training. And that theme is that global health really means that we ensure that everyone everywhere gets the care they need. And where we've come is a remarkable place in the world. We are, we spent the last century defining that we can identify more than 70,000 different ways that the human body can fail, 70,000 different diagnoses. And now we have 6,000 drugs, 4,000 medical and surgical procedures, and at least a couple thousand public health interventions that altogether, when you have access to them and can afford them, and they're delivered appropriately, you can count on now having almost double the life expectancy that people had at the start of the last century. We can live into our mid-80s on average, and with remarkably better health overall. But that access and that capability is not provided it's only provided for part of our populations. Even within the United States, we have large gaps in availability and capacity to deliver that. And it's certainly true around the low and middle income world. And global health to me is about that aim to close that gap. Our job is to deploy that capability of discoveries town by town to every person alive. I've argued it is humankind's most ambitious endeavor. We are a generation who are going to be responsible for learning how to make it possible for all countries to deliver on it, to get to every corner of their societies, and do it in ways that don't bankrupt their societies. And make it work. And there isn't a country in the world that's not struggling with this. And so, it's to understand that none of this is easy. This job was such an opportunity for me because we saw that COVID, I think, changed the equation on health equity. People suddenly understood that something that I've been saying for a long time is that we have had a century of breakthrough innovation, but we've not been matched with follow-through innovation. We haven't made the investments, we haven't made the follow-through in delivering on the capacity to deliver those breakthroughs. And COVID made it starkly clear it wasn't enough to discover the vaccines, to find out that, to find out how to make inexpensive rapid diagnostic tests, to do the genomic sequencing to find the variants, and then discover antiviral pills that, if you're unvaccinated, can still reduce your likelihood of death if you're high risk by almost 90%. We still have to deploy these capabilities. And so although the world is past 60% vaccination, for example, for COVID, we still have sub-Saharan Africa at 15% vaccination. And so that has woken people up around the world to the realization that you need to be able to track not only whether we have the discoveries, but that it is possible and feasible to deliver on equity. So that led to my wanting to join, to take the very kind offer from the president and from Samantha Power, who leads USAID, to lead the global health program at USAID. These programs are around the leading, most common killers in public health around the world, addressing maternal and child illness, addressing infectious disease, HIV/AIDS, and building the infrastructure and health systems capacities of other countries to manage their whole population's health. This is a job that's remarkable. I have 2,500 people who work for me, predominantly located in 63 country teams around the world that touch almost 100 countries. These are low and middle income countries where the aim is to foster their ability to meet their burden of illness and their highest causes of life, loss of life expectancy. And so that has really fed, and I should say also that it's done through partnerships with the country's governments, also with other nations and multilateral organizations, and with NGOs and the private sector, and also with academic institutions. And Dean, you know, Johns Hopkins is one of those really important institutions. For a couple examples, we work closely with Breakthrough Action, which is a Johns Hopkins program that is really the premier social and behavioral technical capability and how to drive messaging and programs that reach the right people with the right messages and the right approaches to be far more effective, whether it's family planning, tuberculosis care, or other kinds of areas. And then we also have the relationship with Knowledge Success, which our Office of Population and Reproductive Health works with as our leading knowledge management program. And so thank you for all that you've built and all you're doing to help partner in these efforts that we lead around the world. My priorities coming in are, number one, to control COVID-19, which means turning it into a manageable endemic respiratory illness. Our programs include enabling vaccination of the world with already more than 500 million vaccines that the United States government has donated. I co-chair the COVID task force at USAID. We know it's not just about the vaccines, and so we are driving more than $1.7 billion in programming for getting vaccine delivery capacity increased around the world to accelerate our vaccination, especially in sub-Saharan Africa. We launched an effort just in the past few months in 11 target countries in sub-Saharan Africa, and and I've only been in place a little over 3 months, but that effort in a matter of weeks, driving campaigns, has been part of 8 of 11 of those countries now getting over 25%. These were countries that were all below 10%, and we have virtually all except one above 10% now, in addition to the 8 that are over 25%, and we have more to go. We have what we call our Saving Lives Now program, which is about the non-vaccine components of care, building out oxygen systems so that people can get therapies, which happens to also be helpful when it comes to childhood pneumonia, which is the biggest killer of children under 5. We are working on deploying and testing test and treat capabilities, not unlike we have in the US with oral antivirals, bringing that into the low-income world. We have our second presidential summit coming up on May 12th to marshal the capacity of other countries in the world to deliver on our joint agenda that needs to be delivered for equity in COVID survival and COVID prevention. And we're hard at work at persuading Congress not to defund our COVID-19 efforts. Just because this surge is in abeyance does not mean that we can afford to be unprepared for the next surge and future variants to come. Second goal is preparing for the next pandemic, and I'll be happy to talk with you about what that really means. But cores of it are increase in the number of countries that have capacity to detect and respond to outbreaks, but also the ability to have more effective emergency response for health disasters of all kinds. And that was part of the reason I was in Ukraine, is standing up our rapid response capacity for protecting health systems and addressing risks of public health needs. And then finally, it is around strengthening our global health systems, especially primary care systems. That's my third big priority. We now know that we have, in the last 2 years of this pandemic, have endured the first reduction in global life expectancy in more than a century. And the cause is not just COVID infections directly. That's in fact the minority of the excess deaths that have occurred. We've seen large increases in excess deaths among children under age 5, which has to do with breakdowns in our health systems that have occurred in this pandemic. Lots to talk about there, but it is my strong observation from now more than a decade of work trying to support global primary care that we have a need to have a major agenda that to make concrete investments that can dramatically, I think, increase and recover our losses in primary health care and in life expectancy, that this will make a substantial difference. The president, in his 2023 budget, made a historic investment in global health that has not gotten very many headlines. A dramatic increase in funding for our direct global health programs, but then where we have currently $4 billion in funding, but then a $6.5 billion investment in building out our global health security capacity around the world, including major investments in health workers and ensuring that health worker capacity is there in the places that need it. The primary health worker capacity is how you learn about, that's the first contact point for people who are sick with potential pandemic diseases, for knowing how to take care of them, how to make sure that attention is there for how getting them diagnosed and reported, and action to be taken to contain the disease. So there is a lot there for me to do. I can talk about even more. I will turn it back to you, and we can talk about it. But I've been in place for 3 months, and everything people predicted about being beaten down by bureaucracy and finding the cynicism that will be coming in, I just haven't found that. The people are extraordinary, the technical skills are remarkable, and it's and the opportunities to have people all pulling in the same direction and working together is really very, very gratifying, and I've been very energized.
Great. Well, thank you for those opening remarks, and it's wonderful to see a major investment in global health and global public health, and we're looking forward to all that you're able to do over the years to come. And also thank you for the shout out to what we're doing here at Johns Hopkins, and we're just so proud and honored to be partnering with USAID in some very important programs. Of course, we have lots of questions for you. Unfortunately, we don't have as much time as we'd like, but let's get right to it. And perhaps we could start with how you got to where you are today. You've remarked that your parents, who met in Brooklyn in the 1960s, as I recall, as young doctors from India, could not have imagined a child of theirs serving in the role you currently have. And you've already touched a little bit on the ways you count yourself among the beneficiaries of USAID's vital work. But could you tell us just a little bit more about how that came to be and how you are where you are today?
Yeah, I should say a couple things about how I myself benefited from the USAID's work. My grandmother died from malaria under age 30. And before USAID had ever come to be, and I have little question that the President's Malaria Initiative, which is coordinated by USAID's or housed at USAID, if it had been there, that she would be alive today. That furthermore, the Green Revolution, my family on my father's side are subsistence farmers who would have malnutrition and harvests were the defining feature my father described, and for my grandfather as well, times that they starved and people died from starvation. And the Green Revolution in the 1970s turned my father's village into an food exporting community, let alone an exporting country. But the most direct thing was that when I was born in New York, and then raised in Ohio, my parents actually had a plan to return to India, but I had a reaction to the smallpox vaccine. I had an anaphylactic reaction that meant that I could not complete the series, which meant I was not allowed to leave the country or enter India, where smallpox was widespread. 1979, smallpox was officially declared eradicated, and I was allowed to travel for the first time to India, and I couldn't have a career in global health at all without having been able to join the bureau that had led the smallpox implementation program that made it possible for me to be here in the first place. It's remarkable. I did get to describe a bit of the pathway that led me here, and I think the thing that is unique and exciting to me about USAID is it's an implementing organization. It is about operations. It's about on the ground delivery through partners touching hundreds of millions of people. And the opportunity for scale and seeing it in action is just, it is remarkable. I'm learning so much. It is the work I've been doing for now 25 years, but especially over the last 15 years, first in surgery and improving safety in surgery and getting programs implemented around the world, but then in childbirth, primary care, and end of life as well. And I get to advance that work across an even wider spectrum and with a wider footprint than I could have ever imagined.
Yeah. So, as you talk about your previous roles, and we do know you best as a surgeon, a professor, a public health leader, as well as an award-winning author. But now you are sort of switching roles, and you have a major job in the federal government. And I'd be curious, you spoke a little bit about what you are so grateful for in your current position. But could you talk a little bit about what's been the biggest challenge for you in transitioning? This is quite a different role for you, and any surprises that you've encountered.
I still am trying to find a day when I can make it through the day and know all the acronyms everybody uses.
Right.
Government is an alphabet soup. And how to connect policy goals to finance, to make it so that the money can be aligned with the goals is very complicated. So, I would have thought coming in that the relationships with Congress and the kind of partisan politics would come into it, but global health is actually well supported by both sides of the aisle, and there's strong desire to move on those sides. And the teams on all sides are knowledgeable and capable, but how to make things move, make them move nimbly, and 99+% of the funds are earmarked. And so in global health, that means you're tied. And what I want to ensure we're doing is prioritizing our work according to where the best outcome per dollar is for achieving improvements in life expectancy and reducing global burden of disease. That profile has changed, right? A lot of the dynamics of public health have shifted in the last 20 years. The earmarking process has focused on infectious disease, maternal and child health issues, and those are all fundamentally important. That's probably half of the loss of life expectancy. But cardiovascular disease is now the biggest killer in the world. Mental health is one of the largest causes of burden of global illness, and we now have programs and approaches that are there. And I think the key aspect is that all of this work flows through primary healthcare as its starting point, and strengthening primary healthcare system capacity can enable people across the lifespan to, it at least is the cornerstone of successful public health, is marrying our public health goals and interventions to primary health systems that touch people through community health workers at the community level and connect them into clinic capacity for the next higher level needs. That is, I think, the big opportunity and the great complexity, the difficult thing to make happen.
I couldn't agree with you more. And I'd like to return to the issue of mental health in a few minutes, and also the importance of primary care. But let me talk a little bit more about the pandemic and where we're headed, because it's on everybody's mind still. You talked in your welcoming remarks that we've met a lot of challenges over the last couple of years. And it does remind me of what Søren Kierkegaard is known to say, that life can only be understood backwards, but it must be lived forwards. And to me, that's a maximum that holds a special meaning for us as we start to climb out of this pandemic. So can you expand a little bit more on some of the lessons that you think we've learned, and how we can use them and apply them to prepare for the next pandemic? We've been here before, as you well know, and there's a flurry of activity and funds that are put into programs for preparedness and prevention, and then people forget. How do we avoid that from happening, and how do we really prepare for the next pandemic? And I'll just add to that. You talked a little bit about what USAID is doing to ensure vaccines are available worldwide. That's clearly part of the preparation that we need in thinking about the next pandemic. So could you just talk a little bit more about some of these lessons we've learned, and how do we make sure that we leverage this important point in time and to do the right thing moving forward?
Well, so many lessons, but let me just pick out a few. One would be that systems really matter. The places where we have made investments in systems have been the places that did the best. Interestingly, our measures of pandemic preparedness in the systems, whether you have a laboratory capacity, whether you have certain kinds of tools, did not correspond with the places that did the best in the world. The US had the highest rating in system capacity, having the tools, et cetera. And we did among the worst of the higher income countries. It's where it's where the places, I think that the pattern that was different was, it wasn't just whether you had them, it's whether you were using them. And the programs where there were active efforts, for example, in tuberculosis, those systems were actively using tools like GeneXpert, which are PCR testing capacities, and could, the people were practiced and know how to use those systems and turn it over from TB to COVID testing, that the workers knew how to track and make sure that people got appropriate treatments, that they could follow up for directly observed therapy for DOTS, and knew how to transfer those skills over into this work. We saw that with PEPFAR, we saw that with malaria. Those platforms had tremendous extensibility and value. Whereas countries that didn't have that kind of active functional platform in place, having the laboratories, having the guidelines and textbooks and programs didn't mean you knew how to make it function. And I think that is a really important part of how we make that work. That we need to be able to, just like the banking stress tests, which look at not just whether they have the controls in place, but whether if you stress them, you could actually see it happen, see the pieces fall together in the appropriate ways. We don't have that in health, and I think we need to use that. At the present time, so I'll give a second example here. There's an Ebola outbreak that I'm part of responding to in the Democratic Republic of Congo now. In Guinea and West Africa, in 2014, it was 4 months from being able to, for a case that had occurred to get identified and then get notified up into the public health apparatus. Last year, because of the buildup of our COVID work, there was only 15 days to have that response. However, you'd like it to be even faster, 2 weeks for Ebola or a major disease to spread like that. is not fast enough. You'd like it to be within 7 days that occurs, and just 1 day to get then confirmation and actions started. And so this week, last week was a case of Lassa fever in Guinea. This week was in DRC. We have an acceleration of these outbreaks, and we have been investing at USAID and as well as CDC and other parts of the U.S. government in building laboratory capacity, training workers and how to identify these, notifying people about it. And that response was in 2 days that they took them from case identification to notification for both of these outbreaks. Within a day, you had confirmation, case contacts were being identified, and ring vaccination for the Ebola case was underway. We already have 233 people identified as direct possible contacts, and then their contacts being vaccinated. And so we have one other, it's just, this is how you control and apply the lessons that we have here.
Mm-hmm.
It's about systems matter and demonstrating delivery and extending it through across not just COVID, but to the function of the system is crucial.
So important. Yep. Great. So I think most of us would agree that misinformation and disinformation have really derailed public health initiatives in the US and other countries, especially over the last couple of years with the pandemic. And some see this skepticism, and I hear this from my colleagues every day, that our greatest challenge is this skepticism as we move forward. So I'd love to get your thoughts on what we can do to rebuild the public's trust in science. Are the challenges different in the US compared to other countries around the world? So I'd love your thoughts about that.
Seeing in Ukraine, which has an even higher level of distrust in vaccines, and the result is they have extraordinarily low rates of routine vaccination as well, which is why they've ended up, we've had 2 cases of polio in Ukraine, a diphtheria case last week. It's just remarkable. They have measles outbreaks, and the story is, I think, very common everywhere, though it comes in different flavors. Number one, the major danger is in a few places. It's the uncommon situation, but U.S. is one, Russia is another. Tanzania is an ample demonstration when partisan politics becomes joined to denying the facts of a public health threat. That is extremely dangerous. In Tanzania, it was to the point that the president denied that COVID was anything of significance at all, actively campaigned against people getting the vaccine, and ultimately died himself of COVID infection. His replacement president has been extraordinarily from the same party, but has removed that link between the partisan politics and vaccination or other countermeasures. And so it is an uphill battle. You gain trust in drops and lose it in buckets, as the saying goes. And so her task as the new president in Tanzania is really uphill, and we're needing to rebuild that trust as well. And it is drop by drop. I'd say the second thing is to understand, as scientists, where the line is between the politics and the public health. There are the facts of the situation and the priorities, and then there are the choices to be made about what you do about those facts. In the 1980s, I'm always reminded of that President Carter had put in a 55-mile-an-hour speed limit around the country. And we in public health would say we could quantify increasing the speed limit would cost thousands of lives, and this is the number that lives are lost. And the country still said, too slow. It's just too slow. And we said we're gonna take that risk. We're gonna tolerate that higher rate of death. And we're going to work on countermeasures. We're going to get anti-lock brakes, and we're going to do, a variety of things to work on reducing those. And we moved to higher speed because that was where the trade-offs lie. And I think that that there's been a legitimate dialogue around the risks that people want to take and accept around the country. There are reasons of equity to raise whether that is hitting all populations equally, and that we address questions of who is harmed and whose harm are we willing to really accept or not. But at some level, we have to also be clear that that many of these questions fall into the political arena, where we have reasons to advocate the same way we advocate for people to not smoke, the same way we advocate with our patients in primary care to not, to wear their seatbelts and to cut back on, high risk alcohol use. That we want people to be vaccinated. We want people to benefit because our value is health. But in the larger arena, there are competing values, and being clear when we're making a political choice as opposed to the scientific one is an important space for us to be clear about, and we build trust by being able to speak to the facts and then accept that there's a debate around the values.
Yep. I totally agree, and I think you would also agree that for us in the public health world to learn how to better communicate the science and the facts, if you will, to both the politicians but also to the general public. I think that continues to be a big challenge for us, and one that we really need to address. Let me go back to mental health. You raised mental health as a priority for USAID, and we've seen a lot more attention paid to mental health problems, and they range from increasing suicide attempts among youth and young adults to increasing the burden of populations who've experienced and have been impacted by war and violence. So could you tell us a little bit more about what you see the role of USAID is in encouraging innovation, especially around the issue of stigma of mental illness, as well as access to services, and particularly in low-resourced areas in the world?
Yeah, first thing to understand is the epidemiology of mental health has higher rates than people really understand. I alluded to the importance of the global burden of disease from mental health and the amount of chronic debility that people are enduring around the world. It's one of the most common afflictions that human beings have. And in fact, it's just over 25 to 28% of human beings will have an Axis 1 mental health diagnosis in the course of their lives. And so it's a common struggle, and we all will see it in our families and navigate it. And that is no less true in the low and middle income parts of the world where the vast majority of people live. Furthermore, it is regarded often as a luxury and that we don't have effective methods of managing. But in fact, there have been people in the public health community, including from Johns Hopkins, where I was at the Harvard Chan School of Public Health, and other settings, have really demonstrated in solid randomized trials around the world that there are low-cost interventions, such as some simple cognitive behavioral therapy tools that can be taught to a wide range of practitioners and deployed at large scale, and have remarkable effects in reducing distress and symptoms associated with depression, in being able to identify people at risk, get them therapy that is effective and cost efficient and deliverable, and that again, it's through our basic systems of a community health worker tied to a primary healthcare system that is a backbone that can deliver on these fundamental priorities. But we're still in a place where there is stigma to mental health, and combating the stigma, I think, is about putting systems in place that make it straightforward, that, hey, we recognize these issues. We know how to support people to address them. Really important, we have in our Office of Health System Strengthening work to increase financing and achieve universal coverage and basic primary care coverage, and includes advocacy with the countries we partner with to make sure to include mental health in their package of services. There is a substantial return on the investment, both economically as well as in health terms, but we have a long way to go.
Yeah, we sure do. So I'm getting a cue that we're almost out of time, but I have to get in one last question, especially for our students who are listening today. So what advice would you offer to those considering a career as a public health researcher or practitioner? And how do you think they can best prepare themselves to lead in today's ever-changing world?
Well, if you care about improving the human condition, there could not be a field more exciting to enter. This is going to be, as I said, a generational challenge, how to enable our capacity to give people long, healthy lives and have a chance to achieve their potential. And we have, what's lucky in public health is it's one of the few fields where we can demonstrate we have scaled over and over again across the entire world ways that bring the world together to solve problems. Whether it was eradicating smallpox, on our way to eradicating polio, or a lot of my career was around enabling surgical systems and complex care to be delivered in across the world far more effectively and close gaps in access. There is opportunity, whether you are interested in the medical delivery side and actually being a doctor, nurse, physician's assistant, dentist who can deliver capacity or help build it for the world, or you're a quantitative person who needs to help us solve what's the right cost-effective way to make our choices and deliver solutions. There's possibilities for everybody, people who know how to build organizations and lead them, people who want to change policy, change public priorities. There is, for almost any skill set, it's just a question of, are you excited by solving some of the most complex challenges in the world and doing work that is meaningful and makes a massive difference? I think that's a lot of the population, and this is a channel to provide work that people find tremendously meaningful in their lives. So I could not encourage looking at it more for almost anybody who has interest in making a difference.
Yeah. I, as Dean of the School of Public Health here at Hopkins, I'm always amazed, and I stand in awe of the students who come to pursue their public health career and their public health education. They are inspired, and it's just wonderful to see. And you're absolutely right. There's so much to be done. So thank you for that. Well, it looks like we're out of time already. That was great. I think we're going to have to invite you back, Dr. Gawande, and we have so many more questions we'd like to ask you. But thank you again so much for joining us today and sharing with us such great insights and some personal stories. And I especially enjoyed your story about how you got to where you are today. I'm inspired, and I know our audience is as well. And let me add personally that we are so grateful for your willingness to serve our country and the world in your new role at USAID. I know we're in good hands. Finally, I'd like to thank all of you who joined us today and those who submitted thoughtful and engaging questions. Your interest and participation in these events make them special. We hope to see you at the next Johns Hopkins Health Policy Forum coming up in a couple of months, so stay tuned. Stay safe, everyone, and be well. And thanks again, Dr. Gawande.